to all the respected dignitaries, my seniors and colleagues. I, Dr. Neha Singh, Secretary IIP Raigarh, on behalf of Maharashtra IIP and IIP Raigarh, I welcome you all today for our March month journal journey. Reciting the famous lines, you can teach a student a lesson for a day, but if you can teach him to learn by creating curiosity, he will continue the learning process as long as he lives. In absentia, I welcome MAHA-IP President Dr. Sanjeev Joshi, sir. I also welcome Secretary MAHA-IP Dr. Renu Boralkar, ma'am. President in absentia, President-elect Dr. Vinayak Patil, sir. Central IIP Secretary Admin, respected Dr. Mahesh Mohite, sir, and all the Central IIP EBs of Maharashtra, and MAHA-IP EBs. I also welcome Raigad IIP President Dr. Sachin Morade, sir, past President MAHA-IP Dr. Hemant Gangulia, sir, uh, and rest of the attendees. I also welcome our esteemed experts of today, Dr. Amol Joshi, sir, and Dr. Sagar Varankar, sir. I also welcome the speakers of today, Dr. Alankrita, as well as Dr. Mimansha. I also welcome Dr. Madhvi Ingle, ma'am. I now request Dr. Sachin Murade, sir, to please give his welcome address. Over to you, sir.
Good evening, all the dignitaries, faculty experts, and the presenting team. Today is the third pearl of this year of Journal Journey. Today we are having a discussion about two important practical topics, that is role of steroids in OSA, and another thing is screening in the newborn. Both are very useful topics in our day-to-day practice, and this will help us in updating our knowledge. Thanks to the expert Dr. Sagar Valankar Anabul. And I also appreciate the efforts taken by the presenting team, that is Alankrita Devans. Over to you. Thank you.
Now I welcome Dr. Renu Boralkar, ma'am, Secretary MAHA-IP, to give her words of wisdom. Over to you, ma'am.
गुड इव्हनिंग. होळीच्या शुभेच्छा सगळ्यांना. इथे शब्दसुमनांची होळी खेळूया आपण रंगांच्या ऐवजी सध्या आजच्या दिवस. आणि हा आहे जर्नल जर्नीचा जो होळीचा खेळ आहे तो आता आपण थोड्या वेळात पाहणारच आहे. आता सरांनी सांगितलं की खूप सुंदर 2 टॉपिक्स आहेत आणि इथे उपस्थित असलेले डॉक्टर हेमंत गंगोलिया सर जे पॅटर्न आहेत या प्रोग्रामचे, अलॉंग विथ डॉक्टर मोहंती सर. I would like to thank them that they have associated with MAHA-IP and continued the program. And I also welcome the Secretary and President of Raigad, as well as Dr. Chitra Kulkarni ma'am, the senior pediatrician and also adolescent consultant. And Dr. Mimansa and Dr. Alankrita, the name are so beautiful. I was just thinking that time for Mimansa and Alankrita, I had never heard these names before. So very aptly put by your parents, and best wishes to you. And also I would like to welcome our expert Dr. Sagar sir, and also our own Dr. Amol Joshi, who is from GMC or Chhatrapati Sambhaji Nagar. So welcoming all the delegates on this platform to hear the next 2 topics which are there. Over to you, Neha. Thank you so much.
Thank you so much, ma'am. Now I invite Dr. Madhvi Ingle, ma'am. She is EB of MAHA-IP, and to welcome as well as introduce our speakers of today and the presenters of today. Over to you, ma'am.
Good evening, everyone. For today's journal journey, we have first expert as Dr. Sagar Vakankar sir, who is a very well-known pediatric pulmonologist, allergist, and sleep specialist we all already know. He has been trained at all the well-known renowned institutes like CMC Vellore. He has done his diploma in allergy and asthma from this institute. He has his diploma in pediatric sleep medicine from USA. He has also certified as advanced intervention bronchoscopy training from Germany, and he has been an author of many national international journals, and he has been a speaker for variety of conferences including national and regional platforms. Dr. Sagar Vakankar sir is currently practicing as pulmonary pulmonologist, pediatric pulmonologist and allergist at Jupiter Hospital Thane, Apollo Hospital Nerul, SRCC Hospital Haji Ali, Zen Hospital Chembur, and Surya Hospital. He is also visiting Sion Hospital as an honorary pediatric pulmonology consultant. We welcome you, Dr. Sagar Wakankar sir, as an expert on this platform. Our second expert for today's presentation is Dr. Amol Joshi sir. Dr. Amol Joshi is Associate Professor in Department of Neonatology, GMC Hospital, Chhatrapati Sambhaji Nagar. He has done his fellowship from MUHS. He is also a fellow of International Society for Quality in Healthcare, that is ISQUA. He is an associate editor for British Medical Journey Open Quality Journal. He is a national mentor for POCQI, that is Point of Care Quality Improvement, very important module. He is a state mentor for FBNC, and he is also a trainer for Kangaroo Mother Care, which is at the heart of all the neonatologists. He is a state mentor for FBNC, as already told, and he has many national and international publications on his name. We welcome you, sir, on this platform. The presenters for today's topics are Dr. Alankrita Agrawal. She is a JR from TNMC Baikala Nair Hospital. We welcome you, Dr. Alankrita, for your first topic on intranasal treatments for children with sleep disordered breathing. The second presenter is Dr. Mimansa Parashar, who is SR Pediatrics from Vasantrao Pawar Medical College, Nashik, who will be discussing on advances in newborn screening. Dear Dr. Mimansa, hearty welcome on this platform. I hand over for the further proceedings.
Thank you so much, Madhvi ma'am. Dr. Alankrita, please share your slides. I also request all our attendees to please post their queries in the chat box, and at the end of both the presentations and expert comments, we will take them. Dr. Alankrita, yeah.
Yes, ma'am. Sure.
We are very thankful to all the Maharashtra EVs who are giving us presenters from all the zones of Maharashtra. And we are also very thankful to Renu Paralkar ma'am, who is always so supportive and cooperative and always helping us in these things. Okay, Dr. Alankrita, you can start your presentation.
Good evening, everyone. So today the journal article that I'll be discussing is intranasal treatments for children with sleep disordered breathing. This was published on the January 20th, 2026. This is also known as the MIST plus randomized clinical trial, which was published in JAMA Pediatrics. So the main background regarding the topic for today is obstructive sleep disordered breathing. So obstructive sleep disordered breathing affects around 12% of children and is also a leading indication for adenal tonsillectomy. Surgery, though, improves the outcomes, but it also carries the risk of cost as well as the adverse effects associated with it. So this trial mainly was to see if there are medical measures which will be able to improve the children and hence reduce the specialist referral or requirement for surgery later on. So the first MIST trial which was done, it basically compared intranasal steroids and saline as a treatment modality for obstructive sleep disordered breathing. So it was a 6-week trial which showed that both intranasal steroids and saline resolved this condition in about 41 to 44% of children. So this proved that there was no significant difference or no modality was better than the other in the treatment of obstructive sleep disordered breathing. So this created the MIST plus trial, which showed that if saline is the only first line drug which is used, and if intranasal steroid can be used as a second line in case of the non-responders. So the primary research question which the MIST Plus trial tried to solve was is intranasal saline alone effective as a first-line strategy for managing obstructive sleep disordered breathing in children prior to specialist referral. So as I mentioned before, sleep disordered breathing affects up to 12% of children, and surgery will carry the cost and risk. And the MIST Plus trial tested whether 6 weeks of saline, which was also known as the run-in period, if it's given for all children, and then followed by another 6-week period, which was to compare whether further saline treatment will be responsive or an intranasal steroid can be used for improvement as compared to referring the child directly for surgery. So the primary objective was the efficacy of intranasal steroids versus saline in persistent symptom obstructive sleep disordered breathing children after the 6-week saline run-in. Secondary, it also wanted to test the changes in behavior, improvement and quality of life, as well as the parental surgical intent after this 12-week period of treatment. It also included various subgroups based on their age, the tonsil size for the children, if there was any associated atopic conditions, the weight, as well as the severity, and if there was any difference in any of these parameters in the way that they would respond to the treatment. And the final efficacy at the 12-week mark was assessed. So this was a multi-center, double-blind, placebo-controlled clinical trial, which was done in 2 tertiary centers in Melbourne, Australia. The period of study was from December 2022 to June 2024. The run-in period, which was the initial 6 weeks, all children had received once daily intranasal saline, which was 1 spray per nostril. Following the 6 weeks, the children who had persistent symptoms, that is the ones who did not have any resolution of symptoms, they were randomized as 1:1. Half of the children received intranasal steroid, which was mometasone 50 microgram per dose, and half the group had received saline. Follow-up was done after treatment online, as well as various survey groups that they have, like the REDCap, after 6 weeks of treatment. The participants and its eligibility. So the children who were included aged between 3 to 12 years and would have significant obstructive sleep disorder breathing symptoms. That is a sleep disorder breathing score of more than or equal to -1, or who had been referred to a specialist. This sleep disorder score is based on a questionnaire which the parents have to answer. The exclusions included anyone who already had any prior airway surgery, a BMI of more than 97 centile, if there was any craniofacial or neuromuscular conditions which were contributing to the sleep disorder breathing, severe epistaxis, or if they were already on a steroid or a leukotriene inhibitor like a montelukast usage. Of the 1398 children who were screened, 154 had consented, and finally 150 were enrolled in this study. Based on the demographic, the mean age was 6.2 years, 62% were male, and it was an ethnically diverse cohort. 73% of these children were atopic, and 51% of these children had grade 3 to grade 4 tonsillar hypertrophy. After the run-in, that is the first 6 weeks of just intranasal saline treatment, 29.5% had resolution of symptoms. So this percent of children were not randomized. The remaining 93 children were randomized into 2 groups. So the intervention that we did, initial run-in, as I mentioned, intranasal saline was given 1 spray per nostril per day for 6 weeks for all. After that, the ones who did not respond, for them, they were divided into 2 groups. One group received mometasone 50 microgram per nostril per day for 6 weeks. And the second group received, continued the saline, 1 spray per nostril per day for 6 weeks. Both the drugs were identical in appearance, manufactured by the same company. So that's why this the double-blind study could be performed. And compliance was measured based on a daily diary which the parents maintained. And if more than 80% of the doses were taken by the child, then it was considered to be satisfactory. So the outcomes were measured using the sleep disorder breathing score. So if the score was less than -1, that is a symptom resolution at the end of 6 weeks, it would be considered as a resolution or treatment being successful. Secondary outcomes that were checked were the behavioral changes, the quality of life, as well as the improvement in sleep in the children. Parental surgical intent, as well as their need for specialist referral was also seen. And the durability was seen after 12 weeks of the initial run-in. So total study duration was of 18 weeks. So the baseline characteristics, 150 enrolled children, mean age of 6 years, 62% of them were male, and they should have had symptom onset at least 2.5 years before the start of this trial. The groups receiving intranasal steroids and saline were equal, and based on the and even the tonsillar hypertrophy, which were more than grade 3, were 59% in the ones receiving intranasal steroids and 51% saline. So it was made sure that both the groups had similar other parameters as well, including the atopic children, as well as other comorbidities like ADHD, autism spectrum disorders, or if the children were premature. So the primary results that we saw in the run-in trial, as I mentioned previously, 29.5% had resolution after that first 6 weeks of saline trial. So these were not randomized further. After the 6 weeks of randomized control trial, the group receiving intranasal steroid had 35.6% resolution, and the group receiving saline had 36.4% resolution, which was virtually identical. The risk difference between both the drugs was 0.9%, so there was no significant difference between the two groups, as well as the combined 12-week resolution, if we see, based on the run-in as well as the treatment phase, was 50% overall. The secondary outcomes that we saw, it showed no significant difference between both the groups after the 6-week period. The behavioral changes, the sleep improvement, the quality of life improvement, there's improvement and no significant differences between the two groups. And treatment satisfaction, mostly they were satisfied in both the groups, and there was no significant difference in that either. So as we mentioned, at 6 weeks, the treatment finished. Post that 6 weeks, that is at the mark of 12 weeks when they were again reassessed, the group who had received intranasal steroids had continued resolution of 20% versus 35.7% in the saline group. So this showed that saline had actually a prolonged duration of resolution as compared to an intranasal steroid. Amongst the run-in responders who had received that initial 6 weeks and then were not randomized further, 76.3% was still resolved at 6 weeks after that, and 64.9% at 12 weeks. That means after total duration of 18 weeks also, we had close to 65% of the group which had continued being symptom-free. Per se, based on their age groups, tonsil size, allergies, and any other subgroups, there was not major difference in their response to be it intranasal steroid or saline. And so this made us come to a point that saline benefited all children of obstructive sleep disordered breathing, regardless of age or any other clinical risk factors. Overall compliance, when noted, both the groups had equal, that is more than 80%, as was required in our study. And adverse reactions were also mild and mostly unrelated to the study medications. So the clinical implications were that, number one, intranasal saline is safe, it is affordable and effective, resolving obstructive sleep disorder breathing in 50% of cases over a period of 12 weeks. And intranasal steroids offered no benefit over saline alone, even in the initial non-responders. Prior ionized therapy is the intranasal steroid therapy associated with surgery rates of 52 to 68%, suggesting that medical treatments will reduce the demand and will reduce the referrals that are made. And primary care saline management also reduces the specialist burden, improving access for severe cases. Just a minute. Coming to the limitations of the study. The limitations that the study had include that there was no per se waiting control. So if there was any child who had spontaneous resolution, which even though is unlikely since we had already chosen a cohort which had symptoms for 2.5 years prior to the start, is not included. Otherwise, the other would be that the follow-up was shorter, 18 weeks. So a long-term durability beyond 3 months needs to be further studied. This was a symptom-based outcome study. That is that we do not have any objective testing like a polysomnograph, which we do in cases of obstructive sleep disordered breathing, obstructive sleep apneas. So that we have an objective determination of whether or not there was actual improvement. Coming to the study where it has been conducted, it is conducted in Australian tertiary centers. So we cannot actually generalize it to primary care settings. Now, coming to how this adds to our existing knowledge. So as we mentioned very early that prior studies have always suggested that intranasal steroids usually improve obstructive sleep apnea's severity on polysomnography. So this large trial confirms that saline may also be equally effective. Coming to the previous trial, that is the MIST trial, showed that intranasal steroids and saline both work equally in the initial 6 weeks. So this study expanded it to that we can do a sequential saline approach even in the people who had not responded initially for the 6 weeks. Following that, this also included various other subgroups like the age, the tonsil size, the atopic conditions, and it showed that all these conditions did not really vary the result that we just got on just saline for the 12-week period. And per se, the durability of response at 12 weeks was better in the saline group as compared to the intranasal steroid group. So this supported saline even more than the steroids based on this study. And the current American Academy of Pediatric guidelines recommend specialist referral or polysomnography if there is poor response. But this study shows that we can actually wait for a 3-month period of just saline therapy, potentially improving the primary healthcare pathways for obstructive sleep disordered breathing. Coming to a message to specifically pediatricians in the Indian setting would be that saline nasal drops and spray would be a first line tool because it is cheap, it is safe, widely available, and now we have evidence to support it. Coming to intranasal corticosteroids, it shows that we do not need to routinely prescribe these, and they do not provide any additional benefit over saline. And 3-month saline trial can always resolve symptoms in about 50% of the children. So we can avoid them to be given a specialist burden and even surgery for these children. And we do not even have to categorize them into a subgroup because most children, regardless of age, tonsil size, allergic status and all, have responded to saline. And given the minimal side effects, in a resource-limited country like ours, even in the primary setting, saline will be much more useful. And this is something that even based on the updated IAP guidelines can be included and then further get updated about how we do not require an early specialist referral and instead we can use a 3-month trial period on saline alone. For further study, like I've already mentioned, a long-term follow-up that is beyond the 3-month period should also be done to assess the durability of just saline resolved patients. A probable study with a control arm to distinguish if there was any scope for spontaneous resolution, probably including an objective polysomnograph endpoints along with the symptom resolution so that we have more of a physiological evidence. Since the study was done mainly in a tertiary care center, this should also be applied to primary care settings so that we can see if the results are similar. And all the excluded population, that is maybe children with obesity, with craniofacial anomalies, other ethnic groups should also be included, or a further study should be done with these groups included so that we can increase the generalizability of using a saline first approach for all cases of obstructive sleep disordered breathing. This was my study. Thank you.
Thank you, Dr. Alankrita. You have presented with this very interesting article very nicely. Now I request Dr. Sagar Varankar sir for his expertise comments. Over to you, sir.
Yeah.
Dr.
Very good
Alankrita,
evening
will
to-
you stop sharing? Yes, sir, please.
No, let it be.
Okay.
Very nicely done. Excellent presentation. You're almost taken care of all the points, though I have not gone through too much of this article because of my health issue. But what I understood from this, I mean, it's a straightforward. So, Alankrita, I want to ask you, is it adenoids or tonsillar size is important for SDB? Which is more important?
Predominantly the adenoid size,
So,
which
is
has
there any mention in this article about adenoid size?
so they've included both if children with adenoids are present or not as in one of the subgroups, and they've considered the degree of tonsillar hypertrophy as one of the subgroups who are requiring
So,
treatment.
the operation is called as adenotonsillar
Yeah,
removal.
tonsillectomy.
Okay,
That is
it's
what
not
they've
tonsillectomy, it's adenotonsillar removal. Okay, so TAR, that is what I want to mention. So, what is important is adenoidal size. So, we don't know what is exactly the so the important part where this obstruction happens is nasal passage. So, and the age group, another important point, age group is 6.2 years. That is the mean age group. Okay. So, adenoid hypertrophy goes like this. By 5 years, it is top of it. And then by 6 years, it starts coming down. So, do you think this could be the reason for resolution of these symptoms just by putting one nasal spray, and that too once a day? I would have been happy to see if they would have put 2 to 3 sprays. That helps because you are removing the mucosal irritation, which is the main source for adenoidal hypertrophy. Okay, so if you put nasal irrigation, what we used to call as jal niti, okay, so in that sense it helps, but just one spray. Okay, sometimes it's very helpful. I tell my patient to go out, and if they are playing outside and they're coming back in pollination season, if they do nasal irrigation, that also helps because you are avoiding the irritation. So that also has not mentioned in this particular article. So we never know whether this resolution is because of age factor, 6.2 years. So that is the age where they start involuting, the adenoid size starts going down. So that could be one reason. And 8 years is the age where the breathing pipe becomes adult size as compared to the adult. So that could be another reason. Okay. And another thing is, as you rightly said, that's what I said. Just one spray is not going to help. What about the criteria, inclusion criteria? Do you think that is sufficient for?
no, so they've actually excluded a lot of population, which is a predominant group that actually comes with obstructive sleep disorder breathing. The
Correct. So
children with
that has to be excluded because that completely comes into the different category. Okay, craniofacial abnormalities, then Down syndrome. So that comes completely different. So these are normal kids who are growing well, and suddenly they are developing this type of symptoms. Maybe recurrent respiratory tract infections, maybe allergy. So in this study, almost 50. You mentioned some 55% patients were allergic, atopic.
yes.
So could be that reason that nasal irrigation
Help.
help to remove the those allergens from particular nasal passage, and that could be the reason for improvement. That could be the possibility. No, what I ask you about, what do you think? Another important aspect which I found in this, what do you mean by SDB score? That has not mentioned in this particular study. What exactly this SDB score? We know PSQ, that is pediatric sleep questionnaire score. In
Question.
that
Yes.
we have the obstructive sleep apnea score. But here they have maybe if that PSQ is there, then it's okay. But we don't know what exactly which scoring system they have used, and there is no objective data about what was the obstruction behind. That's what I mentioned. They have not mentioned about the adenoid size or anything else, and it's like all subjective parental questions. Okay, so all these taken into consideration, do you think this should be applied to our Indian scenarios?
Based on the Indian scenario, just because this is a very objective scoring, the SDB score also is something that requires it has 3 questions which has to be answered daily. So per se, the response from Indian parents based on the wide strata that we have, it is not actually possible as compared to the objective maneuvers that we might have. So that would be a more clearer picture on how the children are actually responding. Because even like simpler, like even on children who we label as asthma or anything, we usually give them something known as an asthma diary to maintain. So in that only on day to day, we usually see that the maintenance is not that good. So that just calculating an SDB score might be very difficult, at least in a Indian setting, I believe.
No,
This
I'm
might
I'm asking you the final thing. You said that in Indian context, because PhD is not easily available, ENTs are very much available in India. Not like USA. I have a patient 2-3 months of waiting in USA, in New York. Okay, for just to remove adenoids. For us, tomorrow you operate. Today you send it to ENT. Tomorrow they will operate. So there is no question about expertise. We have enough expertise, but do you think this is going to help us in a longer scenario? Because at present we are seeing so many patients with adenoidal hypertrophy. They are coming with so much because of increase in AQI index, the pollution, the food habits, the lot of uses of antibiotics, so viral infections, all these are contributing towards the adenoidal hypertrophy. So do you think this is going to help just one spray, or do you think we should put more spray, because saline as such has no side effect?
Yes, sir. More will be helpful, sir, because the main mechanism usually which we believe saline works with is mucociliary clearance,
Correct.
and which per se will reduce the adenoid size. So in our setting, yes, a trial is definitely needed. I mean, longer duration also and more number of sprays, not just a single spray per day, which this per se study has done.
So other than this, I don't think there are any no comments from my side, but definitely this study gives an idea that yes, along with your usual medication, if you do saline irrigations at least 2 to 3 times a day in this age group, definitely this is going to reduce the inflammation because of your bad AQI. A lot of dust pollution, the microparticles which are going to stick there, and that's going to cause inflammation in your nasal. See, nowadays kids are coming with continuous nasal discharge. They are snorers, and post COVID era, I have seen every day at least 10 to 15 patients per day, and giving every patient, non-atopic patient, a steroid nasal spray is not going to help, and we are not going to help them as needed. So in that scenario, this study helps us, and I have seen in my patient. So in very bad chronic rhinosinusitis, we give them nasal irrigation like Nasowash, which is available in India, that is Neilmed, which was available in USA. So this is going to definitely help, but not one nasal spray, because of our bad AQI, not in like Australia where one nasal spray helps. But here at least 2 to 3 times nasal irrigation is going to help by reducing the inflammation and definitely by reducing the adenoidal hypertrophy. So wonderful study, though there are some limitations. So PhD is finally very important, but we don't do PhD for every kid. So this, if you Google it, pediatric sleep questionnaire for SDB, you will get it. It's very easily available online, and you can just keep it in your clinic and give it to, you can ask to fill it in mother tongue, like Marathi ठेवू शकता, Hindi ठेवू शकता, and give it to them. This is very, very important, because every day the numbers are increasing, and there are certain criteria when to operate, when to send it for tonsillar hypertrophy patient for TAR procedure. One is like they have very severe OSA, every day are getting up in the night, snoring that is causing that is causing so much of noise that the other room or outside the room also you can hear. If they're sitting and sleeping intermittently, if there is a lot of bruxism, there is um, along with that speech hypoactivity, hyperactivity, school performance, then their dentition is becoming bad, and enuresis, very very important, and speech problem, then they're having some amount of adenoidal facies. So these are the indication we usually ask them to do PhD. And of course craniofacial abnormality, and they're common, that is must for PhD. But these are the commonest condition where we ask for PhD. And then we can send them for if there is continuous hypoventilation and more than 25% over a period of night sleep of CO2, then we ask them for surgery. Not every kid for TAR surgery.
So thank you, Sagar sir, for your expertise comments. So now I invite our chairperson, Maharashtra AHA, Dr. Chitra Kulkarni ma'am, who has selected this very interesting article on missed intranasal treatment of children with sleep disorder, along with ma'am and Dr. Niman Mohanty sir, who is the backbone of Journal Journey, always prepare all the presenters each month for preparing their presentations and all. So I now hand over to you, ma'am, for the next article. Over to you, ma'am. Ma'am, please unmute.
Madam is mute.
Oh, Pallavi, ma'am. Chitra, ma'am, please unmute.
Now I could unmute myself. Thank you
Yes.
very much, Dr. Neha. And thank you, Dr. Sagar, for that interesting insights. And the people hearing this webinar are getting a clear-cut message that we are different from West. Our pollution, AQI index, our children, they are different. And so the guidelines definitely have to be Indianized. Saline nasal wash is very nice, but it requires parental assistance also. That was the point to be highlighted. And secondly, we are different from the ENT surgeons. That was a very good message which we received, and the practicing pediatricians will definitely have insight in that, and they will be more confident in advising the kids. Our second topic is equally interested, and I invite Dr. Mimamsa to present it.
Good evening, ma'am.
Good evening.
Ma'am, should I start the screen sharing?
Yes, yes, Dr. Mamansha, please.
Ma'am, is it visible?
Please make it full screen.
Yes, ma'am. Is it visible, ma'am?
You have to click that editing part. Upside, see, there is,
Enable editing.
yeah,
Just a second, ma'am.
just click that enable editing and then do it full screen. Just below help, see, there is written enable editing.
The brown color taskbar. Protected view, be careful.
I'm unable to. Okay.
Above the slides, you can see a bar protected view.
Just ma'am, 1 minute. Yes, ma'am. Enable editing.
Yeah, now make it
Full screen.
no.
Is it visible?
Please reshare. We cannot. Your slide presentation is stopped.
Okay, ma'am. Is it visible now, ma'am?
It's
Full screen
visible,
is.
but please make it in a full. Yes,
Yeah,
now
yeah,
it's fine.
Yes, ma'am. Yes, ma'am, I'll start. So, good evening, everyone. My article for today is Advances in Newborn Screening, conducted by Dr. Cynthia M. Powell, and it was published in 2025 in Pediatric Clinics of North America. It is a review article with impact factor of 1.9. Now, what is newborn screening? So, it is basically a public health initiative and it detects serious health problems before the onset of actual symptoms. In the newborns, it is usually done within 24 to 48 hours and done by heel prick test. It helps in early intervention. Now, before there is onset of any symptom, if we have done the screening and we know what the child might suffer from, it will help in preventing long term disabilities. So 3.6 million newborns are screened annually in US and out of which 12,000 infants benefit each year. The most common disorders which are screened are inborn errors of metabolism, endocrine disorders, hemoglobinopathies, cystic fibrosis, combined immunodeficiency disorders, SMA, etc. So I've concised this to a table in whatever they are screening in US. So it is amino acid disorders, organic acid disorders, fatty acid oxidation disorders, endocrine, hemoglobinopathies, and lysosomal storage disorders. Now, this started with a Guthrie test for phenylketonuria in 1960s, followed by Wilson and Younger screening criteria, which came in 1968. Now, this criteria stated that only those diseases will be taken in for whom treatment was available. Early treatment should be available so that the severity of the disease can be reduced at the given point of time. Now, the conditions which cannot be detected on routine observation or examination, they are the ones which are taken in. And rapid, economical, and highly sensitive confirmatory tests should be available for its detection. Gradually, tandem mass spectrometry and other expanded metabolic screening came into being. This is the history. So in US they have the system of recommended uniform screening panel RUSP. It has been created to reduce state to state variation. There are 38 core diseases and 26 secondary conditions, the latest addition being Krabbe's disease. The chart that we saw in the earlier slide, it includes all these conditions. This has an intensive process which includes nomination. It is reviewed by the Advisory Committee of Hereditary Diseases for Newborn and Children. An evidence based review is done, followed by voting and approval. So, the benefits, the harms, the feasibility, and the cost, everything is taken into account before any particular disease is included. Now, which conditions and how the conditions are added? So, the nomination come from the clinicians, the pediatricians who are practicing, or the researchers who are studying a particular disease. Now, the advisory committee, it reviews the seriousness of the condition. Then it decides whether we are benefiting from the early diagnosis and whether there is availability of a reliable screening process for the condition. After the approval from the committee, it goes for evidence based evaluation where the history of the disease, the accuracy of the test, the effectiveness of the treatment, the potential harms, and the cost feasibility, everything is studied. Then comes the voting, where if the benefits outweigh the risk or not is taken into account. Then the recommendation is sent to the US Secretary of Health and Human Services. If approved, it gets added to RUSP. So it's a very comprehensive process. And then the multiple states will decide how and when to implement it. Now, the limitations of the current newborn screening is that there can be wrong timing, there can be prematurity, and it results in false negative and false positives. Now, sometimes the screening takes a lot of time before the result is available. So the infant can become symptomatic before the result, and it completely outweighs whatever we had planned that no disability should happen. Then negative screening does not always rule out the disease. So at the end, we always rely on our clinical diagnosis. Even if the screening is saying that a particular disease is not there, And whatever we have studied through the years, it is making us believe that no, clinically this child is suffering, this infant is suffering from this particular condition, then we must go for a confirmatory test. So it requires confirmatory testing. The screening is just a screening, and it requires multiple screening for borderline versus critical values. If critical values are present, so we can directly go for the confirmatory testing. In case of borderline values, multiple screenings are required before we actually go for the confirmatory testing. Now comes follow up after positive screen. So after the screening has come positive, the immediate thing that the doctor is supposed to do is communicate with the family and an urgent referral to the appropriate specialist. Then the confirmatory testing is done. Screening is only presumptive. Risk stratification, critical versus borderline values. Accordingly, disease specific therapy is initiated once it has been confirmed. Now, the main goal is to prevent irreversible conditions and disabilities. So, the treatment has to be started early. And then, long term follow up with specialist, whoever is concerned, family counseling, and continuous monitoring. All of these are included in the follow up. Now, there's a new frontier, the genomic newborn screening. This includes whole genome, whole exome sequencing, the gene panels. Multiple pilot projects are ongoing, like Guardian, and it helps us in detecting disorders without biomarkers. So, we can say that it is more sensitive. Cost is reducing over time, and there is the interest is also increasing. So, it has the potential of inclusion in newborn screening, and it can expand it massively. A consensus came in 2010 that while it detected serious condition in infants that newborn screening could not, but there were also certain inborn error of metabolisms for which plain newborn screening was more sensitive. So it is not like genomic newborn screening can do the same work as the newborn screening which has been doing. It can detect other conditions. At the same time, newborn screening can be sensitive for certain conditions. There are many ongoing pilot studies regarding the genomic newborn screening. For example, I mentioned Guardian. Now, this is for medium chain acyl coenzyme dehydrogenase deficiency. Then we have NC Nexus, which evaluated genomic screening, sequencing, Baby Sequence Project. So it identifies additional actionable disorders. For example, in CFTR, gene and cystic fibrosis, then it has also been work has been going for mucopolysaccharidosis. Then a new development has come in type 1 diabetes mellitus, in which a new drug teplizumab. So this genomic screening has been able to diagnose it early. Then the drug can be introduced, and it has reduced the onset of symptoms by 2 years. So detection rate is 3 to 4%. A lot of work is going on in this regard. The challenges that the genomic newborn screening is facing is that the current RUSP review would be logistically impossible. The newborn screening is already underfunded, and adding more to it is obviously going to cause economical harm. There is shortage of geneticists and subspecialists, limited knowledge of primary healthcare professionals, lack of variant information in ethnically diverse population. So, for example, in UK, there is a population of white. Now, a non-UK white from somewhere else will have certain variant information. So, there is issues of variant information and penetration. Access to appropriate follow-up care and critical. So, availability should also be there for further action. Then there are ethical concerns. For example, we are pricking the infant again and again, so it causes physical burden to the infant. Informed consent or mandatory screening. So the parents have to be involved, and they have to be counseled properly. Consent has to be taken. What is screening? What is the role of a confirmatory test? What kind of disease are we dealing with? All these has to be explained to the parents. Then interference with parental attachment, psychosocial and logistic burdens. Psychosocial harm from false positive. It comes false positive, the relatives and the rest of the people around the infant will also suffer. And delayed diagnosis from false negative. So the symptoms appear and the screening did not give us a positive result. So again, that causes harm. Then comes data privacy and storage. Now, if we actually get this into the procedure, where is the genomic data going to be stored? Is it going to be paid for by the government? Who is going to take care of it? And how much of it can be revealed to the society? Because something new will come up and then we will be studying that particular gene. So a lot of work needs to go around that. The main thing is that whenever genomic screening is happening, a particular there needs to be a balance. For example, a particular gene presents in childhood causing conditions in childhood, and then there are certain genes which will present in adulthood. So we have to find a balance that the diagnosis should not get delayed. At the same time, we should not necessarily unburden the patient's relatives, that even when the symptoms have not happened, that this is going to happen to your kid and these steps need to be taken to keep the child protected. So a balance has to be formed between all of this. Now, the rationale behind the review is that expansion of newborn screening, diseases are coming up, there are new drugs coming up for new diseases. So we need to know that this kind of structured environment exists in different countries, so that newborn diseases can be reduced. Increasing addition of new disorders, growing interest in genomic newborn screening around the globe. Now, there's a lack of clarity regarding the structure in most of the countries as to which conditions to be added, how the evidence is to be evaluated, and the ethical and the public implications. So, through this review, all of this has been explained properly. Now, the importance of the review. Now we are currently updated with the landscape of newborn screening in US. It helps understand why every disease cannot be added immediately. It highlights the limitation of the current screening, introduces genomic screening and whatever pilot projects are ongoing around the globe, and it identifies the challenges before the genomic screening can actually become a routine. Now, the challenges to newborn screening in India. Now, newborn screening in India is basically practiced only in top tier cities where pediatric follow up is mandatory. Most of the places it is missed. There's early discharge, prematurity, home deliveries. So, this makes the implementation of this challenging, and it is done only by informed pediatricians. You have to be aware of what is going around globally, what diseases are coming into place, what are the clinical symptoms that you need to look for, what new confirmatory tests that are present or not. So only an informed pediatrician is able to do it. Now, contribution of economic background of the family. Now, India is a developing country, so obviously not every family can afford a confirmatory testing or a genomic screening. Now, this is the case. So, in most of the tertiary care centers, it is performed, but in the tier 2 cities and remote areas, it is difficult. It is still coming up. And obviously, the lack of facilities like laboratory setup and everything needs to be there. For follow up, also, you need subspeciality. So, that is a big challenge in India. Now, the relevance of the review to Indian setting is that India has a large population and we have different grades of consanguinity over here. So, it causes high burden of genetic and metabolic diseases. So, newborn screening in India has a wider scope. It can help in preventable causes of neurodisability and further reduce infant mortality. Now, this article highlights the need for structured newborn screening. There are many high yield conditions happening around in India, like G6PD deficiency, inborn error of metabolism. These are commonly seen. These are the conditions which we commonly see. And for this, newborn screening in a cost effective manner should be available. Now, there's requirement of genetic counseling workforce, laboratory infrastructure, data privacy framework, and long-term follow-up systems. The conclusion is that newborn screening remains one of the most successful public health interventions. Genomic screening holds immense promise, but careful evidence based implementation is essential to maximize benefit while minimizing the harm. We need a structured approach in India for the same. Basic genetic studies should be made part of MBBS curriculum at a larger scale for better understanding of tests and the interventions that will follow, and implementation of newborn screening at all levels in tertiary, secondary, and primary healthcare centers. So, this is it.
Yeah, thank you very much. And in-depth discussion about this topic. And I also appreciate your knowledge in addition to the article. Now, may I invite expert Dr. Amol Joshi, sir, to give his opinion. And he has added some slides to your
Yes.
presentation as well. Please share that in continuation.
Yes.
Dr. Amol, please.
Yes. Thank you, Dr. Mimansa and Dr. Alankrita, for presenting. Your teachers would be proud. They have groomed you well. You have presented the topics well, both of you. I thank Dr. Sanju Joshi, sir, and Dr. Renu Gulak, Madam, Honorary Secretary, IIP, Team IIP Raigad, Dr. Raigad, Dr. Murade, sir, and also delegates for attending, because attending a journal for practicing pediatrician is really appreciable task, I must say. So, as Dr. Chitra Madam has already, both of them have selected these articles. These are very good articles. I would like to add a few things on methodology, knowledge, and generalizability of this article. Next, please. So, we all know the best way to learn is through the stories, as we have been doing since ages. But stories may not give you the best knowledge. So, the thing is, though Dr. Cynthia Powell, she is from American Board of Genetics or so and so, whatever is the full form is. She is from that organization who is deciding on this RUSP program. But still, she has given a narrative review of what they have done. Okay, it would be better to have a scoping review of what all others are doing. Okay, so scoping review means many other studies are also reviewed. Still better would be systematic review, where systematically authors review 3 or more databases. We all know about PubMed. There are Embase. There are other n number of databases available. Most of them are paid, obviously. But for proper review, a systematic review, the author must follow a particular method of review so that he or she does not miss any related articles in any language from any researchers globally. Okay, and even better would be umbrella review in era of digital penetration, that every home is penetrated digitally. We have so many systematic reviews coming up. So not all systematic reviews are good. So it is better to have an umbrella review where the author actually sees all the systematic reviews and gives comments on that. So that everybody should keep in mind. So not single review, narrative review may not give complete or best knowledge, I must say. Next, please. So coming to this newborn screening. So there is something called as hierarchy of evidence. So if we consider, sorry, I may not be able to point here, but from bottom to top. So I observed 200 cases in last 2 cases in last year, then 200 cases in last 10 years. Then I also checked risk factors for all 200 cases. Then I screened all 1,000 babies to diagnose 200 cases. These are all the steps which would guide us to a better evidence. Okay, next, please. So this infographic is not copyrighted. This is made by me, so anybody can use it. So, okay. So with this hierarchy of evidence, you can see that if you see one or two cases that is anecdote or case series, then we see risk factors of these 200 cases. Those could be with case control studies and then cohort studies for analytical studies. Then also while testing, we check for whether this test is giving me what I want. Like Dr. Mimansa mentioned about false positives and false negatives in different scenarios. So if the test doesn't give me what I want, then I think we need a better test. So that has to be checked, whether whatever test we are doing, is it really helping us as far as compared to the gold standard, that is diagnostic accuracy and reliability testing. And if 10 different people do the same sort of testing, and if they get some result, and those results are analyzed with the systematic review and meta-analysis. Different systematic reviews and meta-analysis will have different opinions or different conclusions drawn by the authors. So still higher in the hierarchy would be clinical practice guidelines prepared methodically by the group of expert people from professional bodies like IIP, National Neonatology Forum, and they take into account not only the evidence, but also the context where this evidence is going to be applied. Like Chitra Madam was also saying, and Dr. Sagar was also saying, that we are not same, we are different. We are Asian, we are Indian, that too we are West Indian, we are Maharashtrian. So our genetics change, our responses change, our context changes. So everything has to be applied to our context. Next, please. Dr. Mimamsa, can you please change the slide? Yes.
Yes.
So how does this impact, what is the impact on this article? Is you must have noticed the title of the article is Advances in Newborn Screening. And this is what is the author's bias. Because she was working with one organization, only working for metabolic and genomic screening, author missed out on so many things here. Okay, so this is what is more important for us as practicing pediatricians. Like, we must all know about jaundice screening before discharge. We cannot let a newborn go home without screening for jaundice. Routine newborn assessment for malformations. It is mandated by the Rashtriya Bal Swasthya Karyakram program screening. So that also we should not miss. Pulse oximetry screening. Again, we all know that every newborn after 1 hour of birth, or maybe at 24 to 48 hours, there should be a pulse oximeter applied to the right upper arm and checked whether the saturations are more than 95%. If not, then there is algorithm to be followed. All newborns have to be screened for hearing. That is a universal newborn hearing screening program, which Government of India has already launched. All newborns have to be screened for eyes, not only for retinopathic prematurity, not only for NICU graduates, but all the babies born have to be screened for the red eye reflex. Then risk-based screening. Dr. Mimamsa mentioned about it also. Sickle cell disease screening for sickle cell is detected by HPLC on dried blood spot in tribal areas. That national program is already running. So that is called as risk-based training, risk-based screening. Then metabolic screening, which this article talks about, is the third last, I would say, important for us. So it tests tandem mass spectroscopy and HPLC by, again, dried blood spot. And important is that she mentioned about 24 to 48 hours, but it is a slight samajh ka fair, where it has to be after 48 hours, not within. Why? Because we want the baby to be breastfed first, because many of the metabolic conditions are going to manifest only after baby starts complete breastfeeding. So it cannot happen that babies NBM, like extreme preterm who are admitted in NICUs and babies on parental nutrition, you can't expect the baby to have same metabolic derangements even if the baby is having organic acidemia or fatty acid oxidation disorders, or maybe urea cycle defects, or whatever metabolic screen we want to talk about. And also it has to be specifically in dried blood spot. It cannot happen that cord blood is taken in EDTA bulb and that EDTA bulb sample is placed on the filter paper for that dried blood spot. It is no. It will give a false result. And also, whenever required, then GCMS, the urine has to be collected for GCMS. Next in line would be genomic screening. Dr. Mimamsa mentioned about the variant, but it is actually variant of unknown significance. It is very difficult for us or for the mankind to say what is a normal genome. We find many aberrations. If the aberration is there, suppose I check 100 purines and primitive bases, and out of 100, I find that 30 are abnormally placed. So that doesn't mean, those 30 are abnormal, doesn't mean that my genome is abnormal. it only means that the comparator used does not have those same 30 sequences. But we all know we are all different. Everybody is different. So the significance of those 30 is still not known. So many of the reports, if you go for genomic screening, you will find that the reports are mentioning this is VUS, variant of unknown significance. So we cannot just take it like that. It has to be with a pinch of salt, because in Indian scenario, all the genomic reports which we are getting, they are comparing still with the databases internationally, genomic database. We still do not have Indian genome database at present, which is actually under purview, and they are doing it now. Maybe after say 2 years or 3 years, we will get a definitive genomic analysis of our context. So till that time, I don't know whether we should go for genomic screening. And there is a next concept of sequential or combined screening also. So TMS, then after that GCMS or genomic screening, or TMS and genomic screening, both at the same time. Next, please. So before going for questions, there is a concept of health technology assessment that I want to highlight for everyone. It assesses for the cost effectiveness of any intervention. So we all know as pediatricians, when the National Immunization Program introduced measles and rubella, we were all surprised. Why did they leave mumps aside? But then recently, when the Kerala public health noticed that mumps people also get admitted, and there are morbidities, many morbidities, and it is actually cost effective to introduce now mumps in the National Immunization Program. So our institutes like ICMR and under many institutes under ICMR, NITWAR based at Pune, they are conducting such health technology assessments wherein they would actually find, oh, if we introduce mumps component in that in the measles rubella vaccine component, will that additional cost save on the cost spent on the care of the patients admitted? And that is how they decide on whether which intervention has to be introduced when. So our system in Indian scenario, scientists are geared up to assess what to introduce when. And there are people sitting at the top from IAP, from NNF, professional bodies, along with the researchers to see when and how to implement things. So that's all from my side. Sorry if I have taken much more time. Thank you.
Thank you, sir. Thank you, Dr. Amol Joshi. आपने बहुत अच्छे से बताया. You have elaborated the things and guidelines. And Dr. Madhvi has asked one question. Dr. Madhvi, you can unmute and ask.
Thank you, ma'am. Thank you, sir. Basically, in the presence of all these esteemed members, I would like to inform you that Navi Mumbai Municipal Corporation and PGIMS has started in a public hospital newborn screening for 7 diseases and hemoglobinopathies from around 6 months ago for all the deliveries which are happening in all the NMMC hospitals. So that is one of the major steps we were trying to get it. My question is, as per the congenital hypothyroidism guidelines from ISPAE as well as IAP, we do our finger prick in 3-well test on Whatman filter paper DBS at 72 hours, and depending on that 10-20, we take all the cutoff values, and these are very well established guidelines across the globe. Remaining all the disorders are being screened at 48 hours. Now I am in a dilemma to give a strategic decision as to what is the time for other disorders I should be considering, because all the guidelines are mentioned around as are at 48 hours, while for thyroid it is definitely 72 hours, because the values are different for preterms and terms at each day. So please guide.
Yeah. Yes, sir.
It is a very difficult question to answer. And माधवी मैडम ने ऐसा गूगली डाल दिया है मुझे अचानक से, because the thing is they have given cutoffs for cord blood, and if there are false positive, then you have to repeat at 72 hours. If you are still not satisfied, 20 to 40, 40 to 60, the cutoffs are there. then you do it again at 14 days. So I think thyroid is a problem, congenital hypothyroidism, which when we suspect, it is better to repeat. There is no harm in repeating the prick for the baby, because not doing is going to lead to more danger. Harm of not doing is more than the little harm of which we think of picking the baby again. So my suggestion or my take would be that we
Sir.
repeat it again, no problem.
Sir, the question is not at all for congenital hypothyroidism screening. That is very well clear. My question is only congenital hypothyroidism is a congenital disorder in which there are established guidelines. But we are doing for PKU, cystic fibrosis, biotinidase deficiency, CAH, G6PD, for which it is variable according to the kids. I have been discussing with LifeCell biomedical engineers, bioinformatics and MD biochemistry people from MedGenome as well, and other endocrine experts from Sion Hospital or DY Patil pediatric endocrinologist. What I have been told is actually it is the lab standards which are given as per the reagents. The way we see for CRP we have 0 to 6 milligram per DL, which might be dependent on the reagent, kit to kit, it will have a different value. But when we discuss about the ethnicity as such, then we don't have the data. And how do we buy the data for other disorders to label it either as a normal range, and then I picking it up and counseling the parents that you probably might land up with some genetic disorder for which I have to expose the child for genomic studies. So how do I do that? Because I have different views which I will share with you after you answer.
Okay. So again, that question is not so straightforward. But simple thing is, until we have our own data, we have to rely on Westerners' data. But good that government of the Maharashtra under public health services, they have started doing this screening program. So maybe we will generate our own data in due course, and after that we will be able to say what is normal for our population.
Sir, she wants sequence. In which sequence it has to be done?
Not exactly sequence. What I meant to say was, supposing the incidence is always mentioned in per lakh population. As per the biomedicist, we have to take around 1,000 people to keep us as a normal range, to decide what is our percentile wise normal range. So what I have been told to get it done from the statisticians is the extrapolation of 1 lakh population. Supposing it is 4 per 1 lakh, then it will turn out to be 0.04 per 1,000. Then I will have to go on 99.99 percentile. So if I'm going to do that, am I following a correct path? Otherwise, I'm going to land up people as a wrong. I mean,
no, madam.
That is what I wanted to.
No. Here the concern is it is a matter of research. You cannot practice it unless data is available. So if you are inferring as per the incidence given by the laboratories कि oh इतना incidence है इसलिए मैं इतने testing करूंगी या करूंगा, but it is not so. हमको normal के भी लेने पड़ेंगे and abnormal के भी sample लेने पड़ेंगे, and then it will tell me कि normal का कितना range है, abnormal का कितना range है. So till that time you are perfectly, because even the legalities, even the medical aspects, everything, unless data is available, nobody is able to judge this is normal, this is abnormal. And so what you are talking about is 99.999 centile is not acceptable at this point of time till we have those many samples available for analysis. So maybe when this newborn screening goes on a large scale and the data is available, that will answer your question, what could be considered as normal and what should be considered as abnormal. But even with that, there will be false positives and false negatives.
True.
Because the normal range also has a limitation. So that would be answered only after the data is available.
Okay. Thank you, sir.
Very nice. Thank you so much. May I ask past Maha-AP President Dr. Hemant Gangolia sir to comment on both the articles?
Thank you, madam. I will surely ask some 2 or 3 questions, practical ones, because the perspective of the journal journey is to, after getting the information, how to implement in our practice. The regarding article number 1, actually she said spray. What time the spray was given? That is not mentioned anywhere. And the amount of the spray, what is the amount of the while giving the spray, the directions and whatever the procedure to give the spray probably affects the thing of delivering the spray. Whether the giving the spray or putting the installation of drops, does it has difference? Because most of the time while using the spray with the population of hours where we practice, sometimes they put the spray, but whether it actually goes or not, that is the question mark. So whether the installation of the drops is better option than using the spray, that is one thing I want. I will tell all the questions, then you just can, Neha or Chitra madam, you can remember this, and then when they reply, they can, because I will forget them. This is one thing. Then whether this use of spray or the whatever, how much it has decreased the incidence of doing the tonsillectomy or adenoidectomy, whatever is there. And really, what are the cases where when these measures fail on the incidence where the adenoidectomy or the tonsillectomy should be suggested? That message if we get from you, this is from first article. So I think the first let us get the answer from this, and then I will ask for the next one regarding newborn screening. Yes, madam.
Dr. Sagar?
Dr. Sagar, Dr. Alankrita, anyone?
Alankrita, tell the statistics.
Sir, amongst the usage per se, they have just mentioned it as 1 spray per nostril was given, and they just created similar devices for both the inhalers.
Mostly they have mentioned mometazone, no? It
Yeah,
was in
like
the article.
both of them, they mentioned it as spray only. They have not per se mentioned about drops in this article particularly. And if installation would vary for the spray and drops, that would be there, but they have only considered the spray in this particular study. And the risk, like that was one of the limitations of the study as well for the adenoid tonsillectomy, that study does not keep a longer follow-up as to how many children finally did require the surgery and how many of the non-responders required a surgery. Do not have a longer follow-up, at least in this trial, which should have been done to know if the children who did respond initially would finally did end up requiring the surgery, irrespective of the medical measures.
Actually, they have used 0.9% saline.
Yes.
So if you just put drop, it's not going to make any difference. Okay, it's going to come out or it is going to go inside without any effect. So spray is much better than putting just drop.
Okay.
It causes nasal irrigation per se.
Okay.
Just if you just put drop, it is not going to help. It's very small quantity, so it's better to put spray. But just one spray, we don't know. So there are so many drawbacks.
So if you go to and see the all types of drops which are nasal drops available, they are not 0.9%, but that is the 0.65 or 0.75%, one thing. And all the nasal drops, if you try to use them, just have the use of this. 1 or 2 brands really gives the good spray. Most of the local brands don't give the good spray. That is my practical things what I'm telling.
Yes,
So thanks for your answers. Regarding newborn screening, actually, see, the questions of newborn screening, whatever Dr. Amol Joshi has explained is wonderful. That slide, I really taken the screenshot of that. But basically, just writing the on discharge paper or the advice on discharge or before discharge, doing all these things, the particulars, how it should be done, if you can give us the copy, it will be better. One thing.
Our sir is not audible. Hemant sir?
Our-
Hemant sir, you are not audible, sir.
Can you hear me?
Yes.
Yes, sir, we can hear you.
Yes. Yes.
No.
Yeah. So, Dr. Amol, sir, you are not getting my voice? Amol, sir, are you getting my voice?
Sir, I did not get the question. Can you please
Achha,
repeat the
now you
question?
are getting my voice. Are you getting my voice?
Yes, yes, yes. Yes,
Ah.
yes.
So
Clear.
regarding this newborn screening, one of the first practical question is this, because I suppose I'm practicing in my area, and delivery takes at the place, which is at the other place, and that just they come for the routine follow. So should I advise newborn screening to them? And if I advise, how to go about it, and where to be done? What are the instructions to be given properly, how to be done, and where to be done? Because this is more applicable in the remote areas where I practice. Then,
Sir, point number one. Sir, shall I answer this question first?
I will complete my another question. Acha, ठीक है. Complete this. Yes.
Okay. So, sir, RBSK, Rashtriya Bal Swasthya Karyakram,
Yes.
is a program launched by Government of India for all the Indian citizens, and it is available at all the public hospitals that they are supposed to provide these screening services. But this regarding this metabolic screening, they launched it in particular areas only as a pilot project for universal all deliveries. It is not there in across Maharashtra. But when it comes to our practice, if the patient comes to me, should I advise or no?
Yes.
Ideally, yes, because I know that if I don't advise and patient lands up with the problem, then it is my loss and it is nation's loss. So we should advise. But again, the question of affordability comes in, because the cost may be a prohibiting factor. So it is up to one-on-one discussion with the parents that pediatrician can discuss and advise the screening. But at least those 6 or 7 diseases which are treatable, if diagnosed in time, must be screened. If not all 40 or 70, whatever the screening panel gives you, but at least those 6 are mandatory.
Yeah. So regarding minimum number of screening, whatever number of minimum newborn screening to be done, if you can give us the guideline for that, it will be better. And when to be done and how to be done. That is one part. And because why I'm asking this question, because something, what minimum thing we can done, and whether there is any guideline by IAP or Neonatology Forum regarding this screening, which is as said as guidelines to be followed by all the pediatricians across the country, because this may vary from the primary level to secondary level to tertiary level. So is there any guidelines which can be shared to us, and the methodology of doing all this screening and where to do? Of course, that depends on the area where we practice, and then we have to get the information from that. But when to do, how to do, and which are the minimum things which we should do? Because why I am asking this question, because this is era of consumerism. So anything happens afterwards, and one more sentence to add. If it is, you may say you will answer this question, but then if you can prepare some, because you are the active member of this forum as well as we concern with the IAP. If you can make a paper, not guidelines, but saying as a recommendations, at least this should be done for the general pediatrician, for the which with that paper should be valid in court of law. Yes.
Thank you, sir. We can take this issue up, because it is not available for from. I'm not aware of any IAP guidelines if they have come up of late. But whatever Indian pediatrics journals, these things are coming up for hypothyroidism. They have their. Dr. Madhavi ma'am also shared a link for this congenital hypothyroidism screening. But for all metabolic screenings, 1 page or 2 page SOPs can be brought out, sir. And I will definitely share this with the Maha IAP platforms. Yes.
Sir, thank you very much. And in continuation with this discussion, may I request Dr. Bela Verma ma'am, she's present here.
She left, I think so.
Oh, really? I could see her.
She left.
It's okay. It's okay. And we will share in the group as well the updates. May I request Dr. Mohanty, sir?
Madam, he is not there. He is in
Sir is not there.
I don't know.
It's okay.
Before you ask anyone, madam, I will just request Dr. Madhvi, madam, also, what are the Navi Mumbai corporations doing? What they're doing, just give the information to us.
Thank you, sir. Basically, it is done at by TMS mass spectrometry as well as HPLC platform. We have for our own setup, absolutely, you all can visit anytime. It is a proper NBS lab which has been outsourced and then taken on a basis for all the NMMC newborns who are delivered. And in the recent future, if human resources part is taken care of, we are planning to extend it to the private deliveries as well. The only thing is, it was a strategical decision how to reach the sample. But if the lab is going to get that much of turnover, probably that also would not be a difficult situation to pick up the sample after the delivery is over. So basically what we are doing is, irrespective of whether it is a normal, preterm, whatever deliveries, we are collecting the sample right now. Then at the end of 72 hours, it is on a 22 gauge Whatman filter paper in which there are 4 wells. It is like ऐसा एवढं मोठं कुंकू लावलं असेल तर जेवढं होतं ना, तसं साधारण 8 मिलीमीटर्सच्या रेडियसचं तेवढा डायमीटरचं तेवढं ते पिट सारखं असतं, ज्याला ते खड्डा म्हणतात. न्यूबॉर्नच्या हिलला आपण प्रिक करतो, त्यांचं वेगळं असतं, आपल्या निडलसारखं नसतं. त्याच्यावरून आम्ही 3 वेलला ते घेतो. त्याचे क्रायटेरिया आहेत, ते कसं झालं पाहिजे, मागे कसं उठलं नाही पाहिजे, म्हणजे जास्त ब्लड नाही जाणार, कमी कसं नाही गेलं पाहिजे, मोर दॅन 3/4 ऑफ द पेरिफेरी इट हॅज टू बी डन. तर तसं आम्ही 72 आवर्सला मी माझ्या सेटअपला केलं आहे, कारण कंजेनायटल हायपोथायरॉइडिझमच्या लेवलच 72 वर आहेत आणि आम्ही आमचा 5000 पेशंटचा ऑलरेडी 23 मध्ये केलेला डेटा आम्ही पब्लिश केला आहे. तेव्हा आम्ही फक्त हायपोथायरॉइडवर करत होतो आणि मग हे पायलट प्रोजेक्ट आम्ही ते एक्सटेंड केलं. तर आता आम्ही त्याच्यामध्ये G6PD करत आहोत, 17 हायड्रॉक्सिलेज डेफिशियन्सी फॉर कंजेनायटल ॲड्रिनल हायपरप्लेजिया, सिस्टिक फायब्रोसिस, PKU, बायोटिनिडेज डेफिशियन्सी, नंतर गॅलेक्टोझेमिया आणि अजून एक मी कुठलं तरी विसरले, असे ते 7. आणि HPLC करतोय. आणि त्याच्याबरोबरच आम्ही आमच्या ANC मदर्सचं, जे मी खूप वर्ष थॅलेसेमिया बरोबर करायचं ट्राय करत होते, तर आम्ही त्या मदर्सचं कुठल्याही पहिल्या विजिटला, जसं त्या या प्रोग्राममध्ये त्यांचं HHH आणि ते सगळं मॅन्डेटरी आहे, तर त्याच्यामध्ये त्यांचं तेव्हाच HPLC करतोय. त्याच्यात मायनर ट्रेट डिटेक्ट झालं, म्हणजे ते स्क्रीनिंगच नाही आहे, ते तर डायरेक्ट त्याचं स्पेसिफिक डायग्नॉस्टिक टेस्ट आहे HPLCची, तर ती करतो. स्पाऊसला बोलवतोय, ते बरोबर चाललंय एकदम फास्ट, कारण त्याच्यासाठी एस्टॅब्लिश्ड गाईडलाईन्स आहेतच, म्हणजे त्यात काही डाऊट नाही आहे प्रोटोकॉल किंवा STG डिव्हाइस करायला. आणि तसं झालं तर आम्ही करतोय. सिकलसाठी आमच्याकडे कार्ड ऑलरेडी आलं आहे, जे NHM मध्ये आहे, पण आम्ही ह्याच्यामध्ये सिकलसाठीचं पण इलेक्ट्रोफोरेसिस आपोआप होतं आहे. तर हे 8 कंडिशन आम्ही करत आहोत, त्यांचं काउन्सेलिंग करतोय. पण जसं मी मगाशी डिस्कस केलं तसं लॅबचे व्हेरिएशन करायला तो थोडंसं व्हॅल्यूचं प्रॉब्लेम आहे आत्ता. आणि सगळ्या गाईडलाईन्समध्ये थायरॉईड सोडून बाकी सगळ्या डिसऑर्डरला 48 आवर्सचा कट ऑफ सांगितला आहे. तर त्या कट ऑफला बऱ्याच एक्सपर्टनी असं सांगितलं आहे की आय शुड कलेक्ट माय डेटा ऑफ 1000 न्यूबॉर्न्स फॉर 48 hours and then for 72 hours and then decide percentile wise where am I falling, and then that will be taken for only Navi Mumbai population, मग वेस्टर्न महाराष्ट्र पॉप्युलेशन, मग आपली साऊथ ईस्ट एशियन पॉप्युलेशन, असं ते स्टेप बाय स्टेप होईल. आणि त्याच्या आधी आम्ही बँगलोरला पाठवत होतो लाईफसेलला, हे तर इन हाऊस वाशीमध्ये होतंय आत्ता. पण त्याच्या आधी आमचं डेली कुरिअर बॉय असायचा, ते सॅम्पल आमचे फ्लाईटनी लाईफसेलच्या तिकडच्या लॅबमध्ये जायचे, तर दे कॅन बी प्रिझर्वड ॲट 2 to 8 degree सेंटीग्रेड ऑल्सो. आणि आमचे बाकीचे कुरिअर बॉय दुसऱ्या सेंटरमधून सध्या पिकअप करताय, तर त्या बेसिसवर ते होतंय. रिपोर्ट्स आर अवेलेबल ॲक्च्युली ऑन द सेम डे, पण बॅकलॉग खूप आणि टेक्निशियन कमी आणि त्यांचं डायल्युशनचा कॉम्पोनंट, कोणाला सेंट्रिफ्यूज किती वेळ करायला लागतं, त्याप्रमाणे त्या वेलमध्ये थोडंसं वेगवेगळ्या वेळेला जातं आहे, म्हणून वेटिंग पिरियड 4 ते 5 दिवसावर जातो आहे. आणि वी हॅव आर NMMCमध्ये आमची ना लिंक वर्कर आणि आशाची सिस्टीम खूप स्ट्रॉंग आहे. तर मग जर आमच्याकडे रिपोर्ट घ्यायला कोणी आलं नाही तर आम्ही त्या अर्बन हेल्थ पोस्ट UHPMOला आम्ही कळवतो, त्यांना इन्फॉर्म करतो आणि तिथून त्या पेशंटला परत फॉलोअपला बोलवून घेतो. फक्त मला नंतर मग त्याचं मी मेडजिनोम बरोबर टायअप केलं आहे, त्यांच्याशी मी कॉस्ट खूप 1/4 करून घेतली आहे जर मला त्या फिनोटाईपवरून मला कुठलं जिनोमिक सिक्वेन्सिंग हवं आहे तर. आणि माझं ते पुढचं अजून थोडं राहिलं आहे की ते रेफर नायरला होईल का मग पुढे कोणाला. आणि आत्ता आम्ही मेडजिनोम बरोबर SMA साठी टायअप करत आहे मी, स्पायनोमस्क्युलर ॲट्रोफीसाठी, तेही फ्री सॅम्पलमधून होईल. तर असं चालू आहे.
गुड.
सर
अजून
एक गोष्ट सांगायची, तुम्ही सिकलचं बोलत होतात ना, तर महालॅब म्हणून NUHMच्या अंडर ना ते फुकट होतं, पूर्ण फ्री होतं.
Sickle cell is done and they do for all patients. all सर्वांना करतात ते. आमच्याकडे कुणालाही इन्व्हेस्टिंगला पाठवला, सिकल सेल इज डन फॉर एव्हरीबडी.
बरोबर. तर म्हणजे दॅट इज वन गुड पार्ट.
So very nice, and thank you for the valuable inputs. Even for the viewers also, it will be very helpful, and we can tell to others. Those who are practicing in Navi Mumbai can refer to Dr. Madhvi if any doubt, anytime. Bela Verma ma'am is not there for comments. Has she again logged in?
No, she is not there.
It's okay. Now it is time to close up, actually more than 10:30. The next month topics I want to announce. It will be autism may not be a male dominated disorder. Very important topic, and please again log in 1st of April. Though it is 1st of April, it is our Journal Journey Day. The second topic is UTI in children. Again, our day-to-day practice. And the third, out of 3, we are going to choose 2. Third is a systematic approach to evaluate sudden unexplained death in children. So these are the 3 topics for our April Journal Journey. And zone-wise, Dr. Neha is going to announce which zone of Maharashtra will present this. Please do log in. And now this is time for vote of thanks. Dr. Neha?
मॅडम, ऑटिझमचा ठेवा, कारण एप्रिल मंथ इज ऑटिझम मंथ.
Yes, definitely. Autism is, out of other 2, we have to select according to the willingness of the zone. Over to Dr. Neha.
Thank you so much, ma'am. So today we had 2 very excellent topics selected, both by Dr. Neeman Mohanty sir and Dr. Chitra Kulkarni ma'am. Wonderfully presented by both the presenters and very useful expertise comments from our both experts. I would like to thank Dr. Amol Joshi sir and Dr. Sagar sir for accepting our invitation and being the expert for today's journal journey. Sir, both your guidance and expertise comments were very informative for the general pediatricians, and we are very much thankful to Dr. Neeman Mohanty sir and Chitra ma'am for doing all the hard work behind each session of journal journey, right from selection of articles, presenters, and finalizing the presentation and preparing for each session. I would also like to thank both our presenters of today, Dr. Mimansha as well as Dr. Alankrita, who have presented very beautifully both the presentations. And I would like to thank Maha IP President, also Secretary, Raigad IP President for giving us their support and platform. I would like to thank Dr. Hemant Gangolia sir, Dr. Bela Verma ma'am, Dr. Madhvi Ingle ma'am for joining us and giving their useful comments and as well as the discussion on both the topics. And thank Dr. Pallavi ma'am for the technical support, and also thanks all the attendees on Zoom as well as YouTube Live for joining us today. Requesting all to please join on 1st of April. Thank you all. Good night.
And we want to thank Dr. Neha for systematic things to be done. Thank you.
Yeah. Neha is backbone of Raigad IIP. We must thank her in first.